Good evening. Thank you for joining us for the National Health Service Corps' 2012 webinar series. Tonight's webinar, New Models of Care, A Provider Survival Guide, is presented by Dr. Verna Little. We are fortunate to have Dr. Little presenting a second night in the webinar series. She is currently serving as Vice President for Psychosocial Services and Community Affairs with the Institute for Family Health. She is responsible for the administration and delivery of behavioral health, community, and grant-funded programs in 26 centers throughout the New York area. One of tonight's objectives is to define what you can do to get started with new models of care. NHSC is pleased to offer continuing education credits of 1.5 hours for all disciplines participating in this webinar. To receive credits, you must attend the full 1.5-hour session. Attendance will be verified throughout the webinar with poll questions. Once you respond, your attendance will be noted. At the conclusion of the presentation, the operator will provide instructions on how to submit a question through the conference bridge line. You may also type a question on the screen at any time. There will also be an evaluation after the question and answer session. We would appreciate if you took a few minutes to fill it out so we can continue to improve our future sessions. Thank you again for joining the 2012 NHSC webinar series. We hope you find this webinar useful for your efforts to provide service in your community. Now, please welcome Dr. Verna Little.
Hi, good evening. Thank you so much for taking some time this evening to spend with this webinar. A couple of things to start off with. First, I'd like to apologize for my voice, which should hold out for the webinar, but is certainly not what it usually is. The second is that as we go along, if people would like to type in questions, then we can have some discussion during the webinar, or I can try to address them as we go along. So please feel free to do that. So what we're hoping to do tonight is to talk a little bit about what the definition and rationale for integrated care is, to talk about primary care and patient-centered medical homes, to talk about ACOs, and to talk about what you can do to get started with some of these new models of care. And to think about care really is changing, I think, for those of us who have been in healthcare and community health for a while. This is one of the times that we remember as being the most transient and so much going on. It's almost as if you can't keep up with it. And there's a real transition for enhancing access, and there's a lot of focus on extended hours and open access schedules. And also payment, and really transitioning away from a fee-for-service model in many places, and sort of nationally is the trend, and to be able to really look at different models of care other than getting paid for each visit, and really looking at quality and getting paid for quality as opposed to quantity, and that people are having coordinated care and care that's integrated, and not just integrated in individual systems, but integrated across systems, and really looking at the whole person and trying to combine all of the services to be able to address all of the needs, and to make sure that people have a physician and a personal physician that they identify with, a primary care provider that they use, and that there's some continuity of care for people. And there are a lot of initiatives out there now. The primary care and medical home initiative is really something that has taken off across the country, and you can see all of the states where there are active medical home initiatives. And actually, you can add New York to that now. This is from 2008, and I think there's a couple of other states in there that I see. So this is really something that probably many of you have heard or have been the topic of discussion, or maybe you already work in an organization that is a medical home. And so the idea is that health homes are coming out of the Affordable Care Act and really looking to target individuals that have chronic conditions, and at least two of them, and chronic conditions that can include mental health conditions, chronic medical conditions or are considerably at risk for a chronic condition. And really looking to try to cut hospitalizations and particularly readmissions. There's some organizations that reported incredibly high readmission rates, 20%, 30% or better within 30 days. And so there's a real focus on trying to decrease readmissions and actually, some penalties for readmissions. And I don't know if people have heard of the triple aim. It actually came from Don Berwick, who was for a period of time with CMS. And I think this has really been put out as the mantra for organizations to keep as a central focus. And I like it, and I think it's important to talk about it in your organizations and to know what it is and to use it as a guide as you move initiatives forward and new models of care. And essentially, the triple aim looks at improving the patient experience, decreasing the costs, and improving quality. So in other words, how can we do things a little bit better? How can we do them for cheaper? And how can we really make sure that we're giving people what they want and what they need? And so all of these health home and initiatives, and particularly coming out of CNS, is that this is really about health promotion and preventive care, and that people really need to have access to integrated care, no wrong door models, that people have comprehensive care management. Some of you may have heard the care management for all phrase, and also longitudinal care planning. And for some of you, this may be the first time that you're hearing this term, and I think that you'll hear a lot more of it. Longitudinal care planning is not just planning across one organization, but actually across systems. And so that if you were in your organization and you were doing a care plan with someone, you would not only involve other disciplines, but that you might involve providers from other organizations in some sort of a shared care plan. And actually that the patient would be able to populate the care plan and participate in the care planning as well. Also around chronic disease management and really looking at managing populations of patients with a chronic disease and being able to use quality to or data to be able to drive quality improvement. So really to be able to try to come up with ways in your systems to be able to utilize evidence-based practices and the data that you have available to come up with some different ways to deliver care. And patient-centered medical homes are really a great place to be able to try to provide some of these services. And one of the things is that really looking at trying to come with very coordinated and integrated care. And I don't know if any of you have been a part of the process for applying to be a medical home with your organizations. But it's not as if, they ask you when you apply, do you have integrated care and coordinated care, and you check yes to the box. They actually want to see proof that your care is coordinated, even if you don't have care coordinators. They want to see team meeting minutes, and they want to see real evidence of collaborative care. And many of the applications to be medical homes are sometimes hundreds of pages because they ask for a lot of supporting documentation. And I think this is a really nice picture for the medical home framework. And I think what it does is it really kind of puts there all of the different pieces that your organization is going to need to address and that you're going to need to address in your own practice. So how am I communicating with my patients, and how am I communicating with my team members, and how am I communicating with the system that my patients have to interact with? And also care management. How am I providing care management? Do I have care managers? Am I going to, bring care managers, or do I have access to care managers in my organization or outside my organization? And if not, how are we going to provide care management? Who's going to take on that role, and what is it going to look like? and access to care. What is access now? And, many of you are used to maybe calling and seeing when the next available appointments are. But this is really about creating systems where patients can come in instead of emergency rooms, or where there's open access scheduling, to be able to really meet the needs of the patients for both urgent care and ongoing preventive care. And patient tracking, and how are you going to track patients? How are you going to track outcomes? How are you going to know who's in your panels or on your census? And how are you going to track what's happening with them? And then some kind of performance improvement tied to that, to be able to set some goals around quality initiatives and be able to move towards, performance improvement. And so I think this is really helpful and can actually be a guide to designing a foundation and a plan for moving your organization or your practice towards being a PCMH. And these are some of the standards, and there's actually, you can get them from the web, and there's certainly guidebooks and all kinds of information out there. But I did pull a couple out that tie into what we just talked about, so that you can see what some of the performance measures are around some of the individual sections. So if you're talking about care management, how are you reminding patients? How are you, giving individuals care plans? Are you giving them after visit summaries, and what does that look like? And how are you getting information from other facilities, discharge plans, and some other pieces? So this information is something that your organization should take and really look at the standards and try to see where you are, and maybe take one piece at a time as you move towards this effort. And practices need to pick 3 clinically important conditions, and one of them now is required to be behavioral health. So many organizations will choose depression because that's something that they've generally a behavioral health diagnosis that they've done some work on, or they have some sort of screening and using the PHQ-9. And that there has to really be some data sources. You have to be able to, produce worksheets, some policy and procedure manuals. You have to be able to show some data, screenshots if you have an electronic health record, meeting minutes, and supporting documentation. And these are all things that are required as you go forward. And these, again, are some of the standards. And then they have what they call must-pass elements. And you must have access during office hours. You must use data for population management. And population management is something that a lot of providers, particularly mental health providers, really haven't had a lot of training or exposure to. So in other words, I'm not just looking at my individual patients, but how am I managing my population of depression patients or my population of diabetes patients? Excuse me, I'm so sorry. And what does that look like, and how do I do that? And many of us were not really trained to really look at population management. And we should be able to talk to our population of diabetes patients or depression patients and talk about what the average PHQ scores are, A1Cs, and to really be able to talk about how you track them and how you follow up. And so one of the pieces that organizations will start with and that are really critical is that in order to meet the key element to be a health home, you have to have a clearly identified team. And a lot of us were not trained to work on teams. And a lot of times what people will say is, providers will say, well, I have nursing and I have a nutritionist and there's a social worker in the practice. And while all of those disciplines might be there, and there might be some collaboration and coordination during the day, these are groups of people who clearly identify themselves as a team. A lot of organizations now are dividing, spaces up into pods and having groups of people be a team that are having morning huddles and look at what's going on through the day, that cover each other, that reinforce each other's care plans. And that if you ask them individually, they will identify themselves as part of that specific team. And that there has to really be some coordination. And you have to address some of the barriers to care, whether it's language or transportation. And there has to be some ability to look at an integrated care plan, to reinforce that care plan across the providers so that if the nutritionist talks to someone about a plan, that the primary care provider will reinforce it and that the social worker will reinforce what the primary care and the nutritionist talk about. And that the care is transdisciplinary. And what transdisciplinary means, it's a step ahead, really, from integrated care. And it means that you not only have a team of people, and a lot of the models coming out now are developed from teams, but to have transdisciplinary care means that you not only have this multidisciplinary team, but that each of the individuals actually have some training about what some of the other people do on the team. And that's really important because that allows them to be able to reinforce care plans and to be able to share care plans and be able to really communicate and depend on each other as a team. And that really needs to be routine for all of the providers in the organization. And really the ability to integrate care to be a PCMH is a requirement. And many organizations now will have the multiple disciplines but still struggle with meeting some of the PCMH requirements. And it's really hard to do. People are, not used to working together all the time. And, I talk a little bit, to folks who are going and really working on integrating services and say, it's kind of like rediscovering the neck, that we're all connected and we need to figure out how to be connected. And I like to start talking, with the integrated care with a quote from the mental health commissioner in New York, and also from the Haag Foundation, where they talk about integration and define integrated care as really the coordination of physical and behavioral health, and that these conditions occur at the same time, and that you need to be able to treat both in order to get really good outcomes. And that we need to be able to treat mental health disorders where people feel really comfortable getting care, and to identify where people's clinical homes are. And so if people have a clinical home in the community mental health center, because maybe they have a serious and persistent mental illness and that's where they go for their care, then we need to be able to provide primary care there. And the same with the community health center, that people need to be able to go where they feel comfortable, and that many times they go to the primary care providers for mental health disorders. And that there needs to be some better coordination of care. So the whole idea of integrated care is to be able to keep coordinated and be able to make that mind and body connection. And the reality is that a majority of the mental health treatment is going to happen in community health settings, with the focus we talked about on being on preventive care and integration. 2/3 of the country's mental health services are actually going to be delivered in community health centers over the next decade. And that doesn't mean that we don't need community mental health providers. What it means is that there is a transition in the system. And a real difference in where the focus is. And also that people are more likely to keep appointments where there are multiple things happening, and people may, be fans of Walmart or not, and that's probably a whole other webinar. But, people go to Walmart because they can get multiple things there. They get up, they go, they get a lawn chair, they can get their nails done, they can buy groceries, they can, buy a potted plant. And so it's the same really when you provide multiple services in one place. If I get up in the morning and I don't feel well, and I say, gee, I really don't feel like going into the primary care provider today or to see the doctor. And then I say, gee, you know what, I was supposed to see the social worker and drop off some papers, and, I promised the nutritionist that I would give my food diary, then what happens is I'm more likely to get up and come in. And so you see that people are more engaged and more likely to keep appointments, and that there's actually some decreased no-show rates. And, the reality is that we have to try to do a better job in our current systems recognizing physical conditions in mental health settings and mental health conditions in primary care settings. And we haven't traditionally done that very well. Primary care providers often undertreat the mental health diagnoses, and many times what happens is providers, I might come in and they might identify me as being depressed, or maybe I, self-identify, or I score positive on a screening tool, and I get started on medication. And then I might come back in a month or 3 months and, how are you doing? Well, I'm doing better. Well, what does better mean? It was never really quantified. We didn't really do a good job. And a lot of people fell off the radar, or a lot of people stayed on medication that may or may not have been as effective as it could be. And screening alone, doesn't really change some of these systems, and it really isn't enough to meet the requirements for this new environment, but it doesn't really mean that you're have a developed integrated setting. To be able to screen for some, primary care diagnoses or mental health diagnoses in and of itself isn't enough unless you're really looking at what some of the results are and have plans in place to be able to improve outcomes. There's many organizations who screen for depression, but when you really talk to them about what they do, how do you know, when somebody screens positive, what happens with that? How do you know, if somebody's getting better? How do you track that? What do you do if they're not getting better? When do you do that? And so those are all the kinds of questions that you need to start to ask of yourselves and your teams and your organizations as you go forward. And also to really think about stigma, that there still is a stigma, around mental health issues, and that people, many times are not going to go from one setting to the other setting. And often people say, stigma of walking into a primary care setting is less than going into a mental health setting. But, I have a practice that is a continuing day treatment program with individuals that, with a mental health diagnosis, that come there every day. And I have a community health center that's a very short distance away. And the patients don't go there because they say, I don't want to go there. I feel like people are looking at me. I don't feel comfortable. I don't feel like people really want me there. And so now we do primary care in the day treatment program. And so to really think about trying to lessen some of the stigma, and to really understand that how your organization is addressing both physical health and mental health, because these are really going to influence each other, and you're not really going to be able to get good outcomes unless you address both simultaneously. And if you look at the folks here on the wheel, what you see is that they're both working really hard, but they're not necessarily working together. And so what happens is, if I'm seeing somebody and I'm putting everything into it to treat their depression, and and the primary care provider is working with them to treat their diabetes, are they likely to go to specialty care? Are they likely to take their medications? Are they likely to eat right if they're depressed? They're not. And so then what happens is the diabetes might get worse, and then the depression gets worse. And so we're both working really hard, but neither one of us is getting a good outcome. And this is about trying to come together, to work together to develop a plan that addresses both the depression and the diabetes jointly with the patient. And so to think about how that happens in your practice and in your organization now. And to think about HONDAs. And many of you may have heard this term. And when I ask you whether or not you see any HONDAs, hypertensive, obese, non-compliant diabetics with a high A1C who smoke, many of you are probably going to say, yes, absolutely. I have whole practices full of HONDAs. And the reality is that most of us see patients that are incredibly complex and complicated. And I think this is a pretty picture of the patients that we all see all day long, who really are impacted by both medical and mental health conditions. And actually, if I wanted to paint a realistic picture of the patients we see, I would take a third circle and fling it up there with substance abuse. And the reality is that many of us see triply diagnosed patients during the courses of our day. And so I think one of the things that you want to try to be able to do is to look at data in your organization and to try to talk to people in your organization and in your practice and on your teams about really looking at the patients that you have in your practice and some of the data that's out there about looking at the health disorders between patients with serious mental illness and patients who don't have mental illness. And it's really astonishing to look at how many patients with mental illness, have other conditions. And right now in our current care system, and I'm sure as you start to go ahead and prepare for some of these new models of care, you're going to want to try to identify places where you bounce patients back and forth. And a lot of times we do this in organizations without really realizing it. A lot of times we have providers that are on different floors or in different places, and where the communication doesn't always happen as it should. And so I might be, coming to the primary care provider, and I might be having terrible back pain and not feeling well, and the provider's running some tests and finally says, you know what, I think, you've been working really hard and you're under a lot of stress, and I think, we can't find a physical reason for your pain, and it might be helpful for you to talk to somebody. And so they might, say, listen, I'd, like to give you a referral to go and talk to the mental health provider. And then, we can all think of a million reasons why I might not get there, because I feel like there's stigma, because my insurance doesn't cover it, because I can't get time off of work, because I can't pay the copay, because I don't want people to think I'm crazy, because I don't think I'm crazy, all of the different reasons. And so, but let's just say I do get there and I sit down with a very well-meaning mental health provider who asks me, gee, what brings you here? And I say, I have this incredible back pain and I can't function. And, it's affecting my relationship with my husband, and I'm having trouble going into work, and I really just can't focus, and I can't think about anything else, and I'm completely, overwhelmed with this back pain. And what they may hear is, it sounds to work with your provider to be able to solve this back pain, and then maybe we would be able to sit down and focus on some of the other issues going on in your life, at that point. And so that's really, what happens during the course of our day. And so one of the things to do as you prepare to do some of this integration and PCMH work is to think about how you transfer patients and what that looks like. What that looks like, and how do you facilitate it, and how do you communicate before and after a transfer. And the reality is that in primary care, we really need to do a better job of trying to identify and treat people with mental health conditions, particularly with depression, because one of the things we know is that many of the patients who complete a suicide saw their primary care provider, within a short period of time. And as you go forward and start to think about doing this work and integrating care and becoming a medical home or working on improving the medical home that you have in your organization, it's really helpful to divide people into buckets. And I like this grid that actually came out of Michigan. It's called the 4-quadrant grid. And what it really does is it helps organizations to think about the kinds of patients that they're seeing and what they do with them currently. And so some organizations might say, listen, we're able to take patients who have very high mental health needs and very high substance abuse needs, but really not patients who have high primary care needs. And so then what do we do with those patients, and who would we work with in the community, or what do we need to change in our system to be able to see those patients? And to be able to say, okay, but we can see the patients with low primary care needs, and what does that look like, and how are we going to do it? And what this does is it helps providers also feel comfortable, because then they can say, okay, I feel comfortable with this population, and so it's kind of a good place to start. And it feels to people like, the ability to put an algorithm in place depending on where people fall in this quadrant is often really helpful. and to think about developing teams to be able to handle each of the quadrants of patients. And we talked a little bit about this earlier in developing a transdisciplinary care team and what it takes to move towards developing these care teams to be able to handle each of the quadrants of patients. And we talked a little bit about cross-training and the ability to do longitudinal care planning and care plans. And one of the things that it's important to do is to really talk to providers and develop a system where every problem is addressed by every provider every time. And people say, well, what does that mean, or why is that so important? And it's really, and a lot of times people will say, well, we don't really have the time to be able to do that. I'm already struggling to do what I have to do in my visits without having to address some of these other issues. And to be able to give an example, one of the things is, I may be seeing a patient for anxiety and have a care plan in place with them to be able to look at a picture to help them relax. And at the end of one of my weekly sessions, I say, gee, I see that you saw the doctor last weekend and that you were now you need to take some medication for your diabetes. How's that going? And so to ask that question doesn't make me, I don't need to be an expert. I don't need to be a physician. And then the patient might tell me, what, it's not going so well. I couldn't afford the prescription. And then when I asked my aunt, she told me that those pills make you fat and that my neighbor had another pill that her doctor gave her for diabetes that she doesn't take, but that she was going to be able to give me. Say, what, it sounds like you've got some questions and that this isn't really worked out for you. The doctor's here today. Why don't we, go and find her and you would be able to see her and maybe, work something different out. And then when the doctor sees that patient, they're going to be able to address issues that might not have come to their attention for a month or 2 months or maybe even 3 months. And when that person came back, they were going to be out of control. They were going to not have been on medications, and it's actually going to take quite a bit of time during that visit. They're going to have a lot of needs. And so the ability to just ask that really prevented that provider from having a train wreck visit a couple of months later that was going to take a lot of time. And so in a provider visit, if the provider asks, listen, I see that you're seeing, Verna for anxiety, and you have you're supposed to have a picture and that helps you relax and calm down. How's that going? Well, it's not really going well because I forgot the picture at home the other day, and, I got really anxious at work and I had to walk out and my boss got upset. And then the provider can say, well, do you have the picture with you? What if we made a couple of copies, and that way you could have a copy for work and a copy for home? Oh, you know what? That's great. And so that's going to save me some time in a visit. And so this is really about working together and trying to reinforce care plans, individual care plans, and also shared care plans to be able to bring diagnoses in and be able to involve them in your care plan. So if I'm a mental health provider, I would have obesity or insomnia in my treatment plan and really be working on some of those issues with patients as related to their mental health conditions. And so to really talk to your teams about what it would be like to talk about every problem, every time in every visit. And this is really hard work, and it's often really hard to try to figure out where to start. And to figure out, who's going to be on the team. Who do you have in your practices that can be on a team? How can you create teams in your organization and actually, define them as a team, be very clear. Not just to say, well, these people work on this floor and they work together in this site, but to actually pull them aside and talk about them as a team and what it means to be a team. And to figure out what buckets of patients you're going to start with and what that's going to look like. Sometimes it's easy to start to do this work if you pick a particular population of patients. And also to think about space. There's not often people will say, well, we really can't do anything with space. We don't have any capital dollars. the reality is, in order to do some of this work, people have to work together in the same physical spaces. And so I encourage you to think about your organization, and maybe there are times when, all of the exam rooms aren't being used or all of the counseling rooms aren't being used, and that you can take people from other disciplines and have them work out of those spaces for periods of time. And you'll see the change in terms of how they work together and how they interact and how they begin to identify as a team. And take people out of their silos and really reinforce the fact that you practice as part of a team. And there's some easy ways to do this across your organization. One of the things to do is to begin to do other activities in teams, to not have individualized discipline meetings as often, to be able to do interviews in teams so that people understand that they're actually getting hired into a team and that they're part of a team. And to look at what some of your initial processes are and your intake processes, and what does that look like. If you go through your organization and look at each discipline or each program, medical and dental and mental health and nutrition and community health worker and, all of the different programs that some of you have in your organizations, and look at the intake processes and highlight all of the information that's the same across all of those, then that's a really good exercise, because then you can think, how can we collect this information and keep it in one place, and how much time that would save us across the board, and what would it look like, and who would be able to do that, and to really begin to think it through is a big step in trying to transition the care. And also to figure how you're going to hand people off to one another. Part of doing this work, to be a medical home and have an integrated setting, is to be able to do a warm handoff. And many of you are familiar with the term warm handoff and handing people from one provider to another. However, sometimes we don't realize that many providers of all disciplines don't actually know how to do a warm handoff, and that many times you'll hear providers say, don't really get that many handoffs from, a particular provider. And we realize that that provider is saying, well, I'd really like you to see the nutritionist or the social worker. Why don't you stop at the front desk on the way out and make an appointment? Versus saying something like, well, Verna's a part of my team, and her and I work together to treat all of my patients with depression, and I'm going to have her join us for the, the last part of your visit today. So those are two very different ways, and as you go forward and do this, you're probably going to find that you're going to need to role model and to role play, how to do a warm handoff. And not only that, but to really talk to people, how is that going to happen? How are they going to get a person from one place to the other if they wanted to? And, is there someone else that can do it if it's between floors? So it pays to really pay attention to what that's going to look like. And also to think about some other suggested starts for doing this work. When my organization started doing integration work, many years ago, I went to the nurse from our CEO who sees patients, and I said to them, I'd like to, get all of the patients that when they come in, he rolls his eyes. And we took all of those folks and we looked at them and we created a team and we really managed them. And we, screened them for depression, and we really, went through and then what happened is we were able to change some of the outcomes for those patients. And what that did was really show that you could take that population of frequent utilizers and put a team together around them and be able to have some different outcomes, not only of the experience in the practice, but in health outcomes and mental health outcomes for them. And so some other buckets of patients, a lot of you are doing work because of meaningful use around smoking, depression and using the PHQ-9, alcohol and substance abuse, or doing expert work, unsafe sex practices, or patients who are positive for STDs, developmental screenings, or another chronic illness. Maybe your organization is doing work around CHF or diabetes. And so how can you do that? Maybe you can add depression to your diabetes registry, as an example. And also to think about promoting your team both internally, so, letting people know that you're really serious about doing team-based work across your organization, and also externally, how are you going to promote it to patients? And this is a flyer that came out of Washington, and I like it because what they've done is they really have where they've identified each of the people on the patient's team, and the patient is there on the top, and this is customized for the patients. And so they know who's on their care team and what they do. And many patients are looking for organizations that do team-based care. And you should also think about including it in your promotional materials and talking about what it means to be a medical home and what patients can expect. And some other steps for starting are to thinking about making a list of all the projects, the performance improvement projects from the last couple of years, and what happened with them and what were some of the outcomes. And how good was your organization at dedicating staff and resources to those projects? And, what would providers and staff say about implementation efforts? What really happened with them, and how can you use what you learned from them to be able to go forward and do this work? And were there ones that were particularly successful in your organization that created some kind of change? And what were they, and why did they create some system changes in your organization? Some of the struggles is that how difficult is it going to be to get providers on board? What does that look like? Are people, how do people feel about working in teams? How do people feel about, sharing care plans? How do mental health providers feel about sharing notes and diagnoses? Where is your organization with technology? Can you use your electronic health record to be able to do, some of this work? And how is the implementation, if that's where you are, of electronic health record? How can you use that to be able to support doing your PCMH work and your integration work? And thinking about what the vision is for your organization. And it's very helpful to be able to, make things that are very small and measurable, that have some kind of a time frame where people in the organization can begin to see some change, and patients can begin to see some change. And you want to really give some credit to those changes, and you want to talk about them across the organization and in staff meetings. And to think about who's going to be on your team, who makes a good team member, and who makes a good team leader. People who like to take some risks and who are not afraid to try things and to keep trying things until they get a good process. And so what you might want to do is identify some people who you think would be really conducive to doing this work and trying to put some systems in place, and choose them to be on your first team so that you would be able to come away from that with some best practices and show some successes to roll this practice out across your organization. People really need to be able to communicate and articulate ideas to each other, be able to solve problems, to say, what, this didn't work today, let's try something tomorrow, and then again until we come to a place where we feel like we have a good, functional team and a model that we can replicate across our organization. And NCQA has a lot of publications out there now to really guide organizations to, to be a PCMH. They have practice survey tools that you can get. There's a lot of information in those where you can go through each of the steps and all of the standards and guidelines. And it's a really helpful exercise to take them and go through and then pick, chunks of them to be able to work on. And this really is a transition in care, and it takes a long time to be able to move, an organization to meet all of these requirements, and they've actually gotten more stringent as time has gone on. And so a lot of organizations will start with doing some integration work and integrating health and behavioral health, and then start to do some team-based work as part of a strategic plan to move the organization to be a PCMH. and to really focus on quality and not quantity, and what does it look like, and really moving towards accountable care. And that's really what you're going to hear more and more about accountable care, and to talk in your organization, what does that mean? Because it's very different to be accountable, for patients on your panel and in your organization and the outcomes for them. And that there is some ability to coordinate across a system or a network of care, and to still require good outcomes for your patients. And things have changed a little bit as we introduce accountable care, and that we're going to be judged on quality of care, and that we're going to get paid different rates for different levels of quality, and that we're going to be eligible to be able to say to payers, and to make arrangements with payers, listen, we'll be able to share some of the savings with you. And that's going to be more and more what payers are going to be, the kinds of arrangements that payers are going to be looking to do, and paying incentive payments for, higher quality care and for decreased hospitalization and decreased utilization. And so to think about how your organization tracks these things now, and what that's going to look like, and to think about who you're using for referrals. I think one of the biggest changes in moving towards accountable care is how we use referrals, and referrals for both specialty care providers and for community providers like substance abuse providers, and really having to pull specialty providers to the table and say, okay, these are the things that we feel are good evidence-based care, and that, we're going to refer people to you, but we're going to hold you to these standards of care. And if not, then we're not going to have you as part of our network. And if you're a substance abuse provider, it used to be where you could say, okay, you want to go to a substance abuse program, here's a referral, and you could send them. And now you're going to want to know, wait a minute, what is the success rate for that program? How much does that program cost? What are some of their clinical outcomes? What are their, numbers of people who complete that program? And that's going to make a difference. And you're going to be choosing who you send people to and creating these networks of care. And it's really now about being a part of a network and utilizing networks to deliver very efficient care and coordinated care across all of these services. And that's really what an accountable care organization is. And for those of you who have not heard the term accountable care organization, or ACO, you're going to start to hear it more and more. There's accountable care organization learning collaboratives and groups that have formed around the country, and ACOs are being approved, in many states across the country. And many organizations are going to be, bigger systems are going to be applying to be ACOs, and those who aren't are going to be applying or trying to work to be able to be a part of the ACO networks. And it's really about the ability to share in some of the cost savings, and also to manage populations of patients. And so to think about, for the first time, really, how does your organization and how do you manage populations of patients, and what does that look like? And an accountable care organization in more detail is a group of providers who come together, who really share governance, and who take responsibility for care and coordination of a particular population. And they're responsible for all of the services and all of the care that that population receives. And the idea is to really align all of the clinical providers to maximize outcomes and savings. And the outcomes are better, at a lower cost, and that's what the goal. That's what the goal is. And so there's a couple of different models for ACOs, and I put them here. And as you hear more about this in your organizations or in your communities, there'll be some talk about whether or not your organization, will be a part of an ACO or be an ACO, and what that's gonna look like. So the idea here is, are you ready to be able to practice in some of these, new models of care? And that you're really going to have to be very conscious about building relationships, for networks, that you're going to have a network of care and a network of services and specialty providers for your patients. That you're going to have to really think about what competencies are for team-based care and increase people's ability and competencies to work in teams. To think about how you get data on the populations of patients that you see, how do you get it, how do you look at it, and how do you respond to it, and how do you, and to really expand your knowledge in managing populations of patients and documenting outcomes for those populations. And right now, how do you assess the quality and consumer experience? Many of us say, well, we have a patient satisfaction survey that we give out yearly. Well, there's going to be some real looking at what you do with that information, and that in and of itself is probably not going to be sufficient to really say that you assess the quality and consumer experience. So to really think about what that looks like in your organization. And to really commit to some IT infrastructure, to some electronic health record system that's going to allow you to get data to help you manage your clinical services. And that you have some sort of a plan, a strategic plan for your organization or for your practice that says that we're really looking at, moving forward with these transitions. And there's some organizations out there that can help you. The National Council on Behavioral Health Care has a lot of information actually on, new models of care and PCMH, as do, the National Association for Community Health Centers and some other organizations. And to think about what some of the competencies are, and to think about how are you changing your job descriptions and how are you changing the roles of individuals to be able to meet some of the needs in this new environment. And what does that look like? And to think about the competencies that your organization is going to need to have, and then what competencies your providers are going to need to have. To really look at what some of the goals are and to meet the quality measures and really talking about involving the patient experience into your quality program and care coordination into your quality program, patient safety, preventative health, and to choose an at-risk population, maybe the elderly or maybe HIV patients or some other at-risk population, to really measure quality, and that's a requirement for being a coordinated care setting. And the idea is that if you can really look at these overarching themes that we've revisited several times during the course of the presentation and really figure out how you're going to incorporate them, then you're going to be able to be successful and to put some systems in place in your practices. And to think about what you're doing now. How do you measure up now? Where are you on the spectrum? What are you tracking now? And how do you do it? And what works and what doesn't work? How accurate, how accurate is the data that you're getting? And how do you really look at the patient experience now, and what does that look like? And then think about, what would you need to help you track the quality and measure your population management, and then try to think of some way to be able to generate that data. And this is actually a quote from the Commissioner of Mental Health in New York, actually retiring commissioner. But I like it because what he's basically saying is that if you can figure out how to adopt these new models of care and to create integrated settings and be able to meet some of the triple aim goals, then you're going to be able to be successful. And that if you're not able to figure out how to practice in these new models in a very quality-driven, data-driven environment, triple aim focused, using networks and systems and population management, then you're really going to struggle over the next couple of years. And so really think about what you need to do. Really educate your team and your staff and everyone across, clinical, operational, and financial about what integrated care is, about what some of the new models are and what some of the terms are. And to think that, you're not alone there out on an island, that you really have to think about working together with other providers in the system, and think about meaningful use for your electronic health record. Patient registries are going to be something that are going to be, required. They're going to be a part of all of the electronic health records at some point. And to think about best practices and decision supports and building decision supports into your electronic health records, and to really focus on measurable standardized practices. Because these models of care, the patient-centered medical home, the person-centered medical home, the clinical home, the behavioral health home, the ACO, all of these are really going to be a part of the environment for quite some time. And all of them have these threads in common. All of them require teamwork. All of them require data-driven services. And so I'd like to stop actually for any questions and discussion.
If you would like to ask a question from the phone lines, please press star then the number 1 on your telephone keypad. There are no questions from the phone lines at this time.
Okay. Wait.
Dr. Little, it looks like we do have a couple questions.
Yes, I see them. How is Obamacare facilitating these changes in healthcare? And the reality is that's a driver, particularly for some of the health home and also for the changes in payment structure and being able to focus on quality care and the development of the ACOs. There's been a lot of support for the development of the accountable care organizations and focusing on quality-driven care and changing away from a fee-for-service payment model. Is there a resource for practices that have undertaken this model already? Yes, there is. There's quite a few. I would say that the NCQ website would be very helpful to be able to do. To talk about specific PCMH, the National Council for Community Behavioral Health website would be another one. And also if you're talking about integrated care, then I would go to the AIMS.org website, which has a lot of integrated care information and tools and support. Would you be kind enough to define the HONDA acronym? Yes, hypertensive, obese, non-compliant diabetics with a high A1C who smoke.
Okay, it looks like we've completed all of the questions.
Right, and I will offer to people here, it's not on this last page, but if people have other questions or would want other resources, then feel free to email me. You can actually go to vernalittle.com and email me through there, and please feel free to do that at any point if I can, send you information or answer any questions that might come up as you start to do this work in your organizations.
Okay. Thank you, Dr. Little, and thanks to all of the NHSC webinar participants. Please take a moment to fill out the on-screen evaluation. Your opinion will help us further develop these webinars. Thank you and have a good evening.